Hi everybody, welcome to our module on rhabdomyolysis. Rhabdomyolysis is a syndrome caused by muscle necrosis, and the reason we're talking about it in the renal section is because it can lead to renal failure and potentially death from renal failure. In order to develop the syndrome of rhabdomyolysis, you need to have some cause of muscle damage, and there are lots and lots of potential causes of rhabdomyolysis, but I've listed on the screen the three that I think are most important for you to know. The first one is intense physical exercise, especially if you are dehydrated. A classic scenario in which rhabdomyolysis can develop is in a runner who goes for a long run on a very hot day and gets sweaty and dehydrated. The next day, that person can develop signs and symptoms of rhabdomyolysis. Another classic cause of rhabdomyolysis is a crush injury that damages muscles. So, for example, if an elderly patient falls to the floor and is too weak and frail to get up and they are pressing on their muscles for hours until someone discovers them at home, that person can develop rhabdomyolysis. And then finally, there are a number of drugs that are associated with muscle damage and rhabdomyolysis. The two that you definitely should know are the statins and fibrates, both of which are used to treat high cholesterol. When muscle damage occurs, muscle contents spill into the tissues and plasma, and this is what leads to the syndrome of rhabdomyolysis. And if you're preparing for step one, knowing these muscle contents is one of the most important things to focus on. So one of the things that spills into the plasma is creatine kinase. This is an enzyme found in muscles. It spills into the plasma when there's muscle damage, and you can detect elevated levels with a blood test, and that's one of the hallmarks of the syndrome of rhabdomyolysis. There are also other muscle enzymes which spill into the plasma. These aren't always measured, but they can be. This includes aldolase, lactate dehydrogenase, and AST and ALT. All of these enzymes are found in muscle tissue, and their levels can potentially go up in rhabdomyolysis. There's lots of potassium and phosphate inside your muscle cells, and for this reason, in rhabdomyolysis, when there's muscle damage, hyperkalemia and hyperphosphatemia are very common. There are also lots of purines found inside of muscles. Purines are bases like adenine and guanine that are used to form nucleic acids. These bases will spill into the tissue and plasma, and they will be metabolized to uric acid in the liver, and for this reason, rhabdomyolysis often results in hyperuricemia. And then finally, one of the most important muscle contents related to the syndrome of rhabdomyolysis is myoglobin. Myoglobin is a protein monomer. It's similar in many ways to hemoglobin. However, it is not a tetramer. So hemoglobin has 4 proteins linked together. There's only one protein involved in myoglobin. It does contain heme, just like hemoglobin. That means it has a porphyrin ring, as I've shown on the bottom right side of the screen, with an iron molecule in the middle. So it has heme just like hemoglobin does. And it binds oxygen also just like hemoglobin, but in this case, it binds oxygen only for use by the muscle tissue in which it's found. Let me make a very high-yield side point about myoglobin and the way that it binds oxygen. In the pulmonary section, I talk about hemoglobin saturation curves. These are curves that chart the partial pressure of oxygen versus the percent saturation of hemoglobin. And hemoglobin has an S-shaped curve like this blue line I've shown on the screen here. Myoglobin does not have an S-shaped curve. It has a curve like this red line I've shown here, and that's because there are no allosteric interactions for myoglobin. Allosteric interactions are changes in the shape of the protein that occur when it binds oxygen. When one molecule of oxygen is bound to hemoglobin, that changes its affinity for subsequent molecules, and that gives it an S-shaped curve. I talk about this in detail in the pulmonary section. Myoglobin does not work that way, so it just steadily binds more and more oxygen until it is completely saturated. Myoglobin is responsible for the renal toxicity that occurs in rhabdomyolysis. It causes renal toxicity through a number of mechanisms. First of all, it can obstruct the tubules. Secondly, it is toxic to proximal tubular cells. And then finally, it can also cause vasoconstriction, especially in the medulla. This leads to renal hypoxia and damage to renal tissues. The renal toxicity of myoglobin is made worse by volume depletion that occurs in rhabdomyolysis. Intravascular fluid influxes into the damaged muscle tissue. This causes a decrease in circulating volume and makes the renal failure and the renal toxicity of myoglobin worse. And the feared outcome of the syndrome of rhabdomyolysis, as I mentioned before, is renal failure and death from renal failure. The symptoms of rhabdomyolysis are muscle pain, weakness, and dark urine from the myoglobin. So as I told you before, one of the classic scenarios for rhabdomyolysis is vigorous exercise, especially on a hot day leading to dehydration. That person could wake up the next morning with muscle pain, weakness, and dark urine, and that means they have developed the syndrome of rhabdomyolysis. The diagnostic hallmark of rhabdomyolysis, as I said before, is an elevated level of creatine kinase in the plasma. Usually it's very high in patients who have symptomatic rhabdomyolysis. A normal CK level is less than 250. In rhabdomyolysis, it's usually over 1,000, and it can get as high as 25,000 or more. If you do a dipstick test of the urine, like I've shown on the screen here, it will be positive for heme. Remember that there is heme in myoglobin, and myoglobin is present in the urine in patients with rhabdomyolysis. The way this test works is that heme has peroxidase activity, which means it can break down peroxide, and this changes the test strip color when you do a urine dipstick test. So a positive dipstick for heme means either hemoglobin or myoglobin is present in the urine. A urine dipstick test that is positive for heme usually indicates bleeding into the urine. That is far more common than rhabdomyolysis. So for this reason, when a urinalysis is positive for heme, the urine is usually sent for microscopy to look for the presence of red blood cells. The classic finding in rhabdomyolysis, therefore, is for the patient to complain of dark urine, the urine to have a positive dipstick test for heme, but no evidence of red blood cells in the urine. If you see this constellation in a board question, you should think of rhabdomyolysis. Once you understand that volume depletion is part of the pathophysiology of rhabdomyolysis, it's easy to remember that volume resuscitation is the mainstay of therapy. IV fluids are administered, usually isotonic saline, and they are titrated to maintain a good urine output. Any electrolyte abnormalities that develop must be treated, and then finally, if the rhabdomyolysis is severe, dialysis is sometimes required. For my final slide, I'll mention hypocalcemia. You should know that calcium likes to deposit in damaged myocytes. What this means is that in the initial phases of the syndrome of rhabdomyolysis, hypocalcemia is common. You have to be very careful about treating this, however, because in the recovery phase, that calcium will be released from myocytes. Levels usually return to normal, and they can even become elevated. And that concludes our module on rhabdomyolysis.